42 years on this bench have taught me that some of the most consequential cases I have ever presided over never actually involved a criminal charge at all, and the matter brought before me involving Dr. Warren Castellan, a cardiothoracic surgeon of considerable reputation at Ridgemont Medical Center, was exactly that kind of case, a civil hearing rather than a criminal one, brought not by prosecutors but by the hospital's own board of directors after an internal review uncovered something that, once it reached my courtroom in the form of a licensing and malpractice review hearing, revealed a pattern of conduct considerably more troubling than the single incident that first brought it to anyone's attention, and I want to walk through the entire sequence of events before I tell you what the board ultimately decided, because the way this case unfolded says a great deal about what happens when institutional power is left unchecked for far too long. The incident that triggered this entire review began on a Friday evening in November, when a 51-year-old man named Harold Jennings, who had been living unsheltered in this city for close to 3 years following a construction accident that left him unable to return to the work that had once supported him, collapsed outside a downtown pharmacy experiencing what paramedics who responded to the scene immediately recognized as symptoms consistent with an acute cardiac event, chest pain. Radiating into his left arm, difficulty breathing, a grayish pallor that one of the responding paramedics, a 12-year veteran named Ruth Alvarez, would later testify she had seen often enough in her career to know exactly what she was looking at before a single diagnostic tool confirmed it. Harold Jennings was transported to Ridgemont Medical Center, the nearest facility equipped for advanced cardiac intervention, arriving at the emergency department at approximately 7:40 that evening, and initial testing, an EKG performed within 11 minutes of his arrival, confirmed what Ruth Alvarez had already suspected. Harold Jennings was in the midst of a serious myocardial infarction, a blockage requiring immediate surgical intervention to prevent permanent and potentially fatal cardiac damage. The attending emergency physician who reviewed his case, a young doctor named Priya Nathan just 18 months out of her residency, immediately paged the on-call cardiothoracic surgeon, which that evening happened to be Dr. Warren Castellan, a man who had practiced at Ridgemont for close to 22 years and whose name, I would learn over the course of this hearing, appeared on a wing of the hospital's cardiac care unit, funded in significant part by a donation made in his honor by grateful patients close to a decade earlier. Castellan arrived at the hospital roughly 20 minutes after being paged, and it is at this point that the testimony of every witness present that evening becomes remarkably, almost eerily consistent, because what happened next was witnessed by no fewer than 6 hospital staff members, all of whom would eventually provide sworn statements to the Internal Review Board, and later, testimony in my own courtroom. Dr. Castellan reviewed Harold Jennings's chart, took note of his housing status, which had been recorded by intake staff as required under the hospital's own social services protocol, and according to the testimony of a surgical nurse named Denise Whitfield, who had worked alongside Dr. Castellan for close to 15 years, and who I want to note testified with visible reluctance, clearly uncomfortable providing testimony against a surgeon she otherwise respected professionally. Dr. Castellan turned to Dr. Nathan and stated, in front of at least 4 members of staff, that he did not believe surgical resources needed to be allocated that evening to what he characterized, and I am quoting directly from 3 separate consistent witness statements, a lifestyle-related cardiac event in a patient without the means or likely compliance to manage post-operative care appropriately, and instructed that Harold Jennings be stabilized medically and transferred, once stable enough for transport, to County General Hospital, a public facility across the city known to be significantly under-resourced compared to Ridgemont, a transfer that, given the severity of Harold Jennings's condition, would require close to 50 additional minutes of transport time during precisely the window in which cardiac tissue damage becomes most severe and most difficult to reverse. Dr. Nathan, to her considerable credit, pushed back immediately, according to her own testimony and corroborated by every other witness present, informing Dr. Castellan that Harold Jennings met every clinical criterion for immediate intervention at Ridgemont, that transfer under these specific conditions represented, in her professional assessment, a serious and potentially fatal delay in appropriate care, and that she did not believe housing status constituted any legitimate clinical basis for the decision he was making. Dr. Castellan, according to consistent testimony from multiple witnesses, responded that he had final authority over surgical resource allocation for his own service that evening, that Dr. Nathan was welcome to document her disagreement in the chart, which she in fact did, a detail that would prove enormously consequential to this case. and that the transfer would proceed as he had ordered, Harold Jennings was transferred to County General at 8:52 that evening, arriving at 9:41, and underwent emergency surgical intervention there at 10:15, close to 2 hours and 35 minutes after his initial arrival at Richmont's emergency department, a delay that the cardiologist who ultimately performed his procedure at County General, a physician named Dr. Amara Osei, would later testify in this hearing had resulted in demonstrably greater cardiac tissue damage than would have occurred with immediate intervention, damage that left Harold Jennings with a measurably reduced ejection fraction and a prognosis for long-term cardiac function considerably worse than it would have been had surgery proceeded at Richmont within the standard window. Harold Jennings survived, which I want to state plainly and with real relief, but survived with a permanent reduction in cardiac capacity that his treating physicians agreed, with reasonable medical certainty, would not have occurred, or would have occurred to a significantly lesser degree. Had the transfer not taken place, this entire sequence of events might well have remained buried within an internal chart notation, one physician's documented disagreement against another's clinical authority. Had it not been for a decision Dr. Nathan made roughly 6 weeks later after learning through a colleague at County General of Harold Jennings's diminished prognosis, she filed a formal complaint with Richmont's Medical Ethics and Quality Review Board, attaching her own contemporaneous chart notes, and it was that complaint that triggered the internal investigation which eventually surfaced something considerably more troubling than a single bad decision made under pressure on a Friday evening. Because once the review board began examining Dr. Castellan's patient records more broadly, a pattern emerged. Over the preceding 4 years, hospital records showed that Dr. Castellan had personally declined or deprioritized surgical intervention for 11 separate patients whose intake records listed them as unhoused or underinsured. In every one of these 11 cases, according to the board's own findings which were entered into evidence in my courtroom, the documented clinical justification for delay or transfer was thin at best and, in the assessment of an independent panel of 3 cardiothoracic specialists, retained by the hospital's own board to review the pattern inconsistent with standard clinical decision-making in 7 of the 11 cases, this is the point at which the matter reached my courtroom, not as a criminal proceeding, since no criminal charges had been filed, but as a formal hearing requested by Richmont's board of directors themselves, who sought a judicial determination regarding the hospital's own liability exposure and the appropriateness of the disciplinary and licensing action the board was preparing to take. A hearing they specifically requested be conducted with full public transparency, a decision I want to note the hospital's newly appointed board chair, a woman named Eleanor Vance who had assumed her position only 4 months prior to this hearing, insisted upon personally, over what I later learned was considerable internal resistance from other members of the board concerned about reputational damage. Dr. Castellan arrived for the hearing with an attorney named Gerald Ashworth, a man who specialized in medical malpractice defense and who opened by characterizing his client's decision on the evening in question as, in his words, a defensible triage judgment made under the pressures of resource allocation that hospitals across the country navigate daily, a framing that I told him plainly, before a single piece of evidence had been presented, I intended to test rigorously against the specific facts of this particular case, because triage properly understood is a clinical determination based on medical acuity and available resources, not a determination based on a patient's housing status or perceived ability to comply with post-operative instructions. We heard first from Dr. Priya Nathan, whose testimony, delivered with the careful precision of someone who had clearly rehearsed exactly how to present clinical facts without editorializing beyond what the evidence supported, walked the court through the full timeline of that evening, her own chart notations contemporaneously documented rather than added after the fact, a detail Priya Chan, representing the hospital's interests in this proceeding, emphasized repeatedly because contemporaneous documentation carries considerably more evidentiary weight than testimony reconstructed after the fact, showed her explicit disagreement with the transfer decision, time-stamped at 8:34 that evening, 18 minutes before Harold Jennings was actually moved. We then heard from Denise Whitfield, the surgical nurse whose testimony corroborated Dr. Nathan's account in every material respect, and who added a detail that had not appeared in the initial internal review, that this was not, in her recollection, the first time she had personally witnessed Dr. Castellan make comments regarding a patient's housing or insurance status in the context of a treatment decision, though she acknowledged under cross-examination that she had not, in prior instances, formally documented or reported those comments, a gap in her own conduct she addressed candidly, stating simply that she had not, until Dr. Nathan's complaint, believed such a report would be taken seriously given Dr. Castellan's seniority and reputation within the hospital, a statement that Board Chair Eleanor Vance, watching from the gallery, visibly reacted to, and which she would return to directly in her own testimony later that morning. Amara Osei, the physician who ultimately performed Harold Jennings's delayed surgery at County General, provided detailed clinical testimony regarding the measurable relationship between intervention delay and cardiac tissue damage in cases of this specific type, testimony corroborated by the independent panel of 3 specialists the hospital's own board had retained, whose written report, entered into evidence in full, concluded that Harold Jennings's transfer, given his presenting condition, fell outside the standard of care that any reasonably competent cardiothoracic surgeon would have exercised under the same circumstances, absent the housing status consideration that multiple witnesses testified Dr. Castellan had explicitly cited. When it came time for Dr. Castellan to testify in his own defense, his account diverged sharply from every other witness present that evening. He testified that his decision had been based purely on legitimate resource allocation concerns. Citing a separate trauma case he stated he had anticipated might require his attention that same evening, a claim that, when Priya Chan cross-examined him regarding hospital records, proved considerably weaker than his direct testimony suggested, because the trauma case he referenced had, according to the hospital's own surgical scheduling logs entered into evidence, been resolved by a different on-call surgeon entirely, close to 40 minutes before Harold Jennings was ever transferred, meaning the resource conflict Dr. Castellan cited as his primary justification had, in fact, already been resolved before the decision he attributed to it was made. I asked Dr. Castellan directly whether he recalled the specific language multiple witnesses had attributed to him regarding lifestyle-related cardiac events and likely compliance with post-operative care, and he stated that he did not recall using those specific words, though he acknowledged, under continued questioning, that housing and social stability are factors he considers relevant to post-operative outcome projections generally, a statement his own attorney appeared to recognize, watching from the defense table, was doing his client considerably more harm than good because it confirmed, in Dr. Castellan's own words, the underlying premise every witness had already testified to, that he factored a patient's housing status into his clinical decision-making in a manner entirely separate from actual medical acuity. I asked him one further question before releasing him from the stand. I asked him whether he understood the distinction between legitimate triage, which considers medical urgency and available resources, and the pattern the independent review had identified across 11 separate patients over 4 years, a pattern in which housing and insurance status appeared to correlate directly with delayed or deprioritized care regardless of underlying medical acuity. He did not have a satisfactory answer to that question. Board Chair Eleanor Vance testified last, and her testimony was, in my assessment, the most consequential of the entire hearing, because rather than defending the hospital's own institutional interests, as I suspect some board members might have preferred, she testified plainly that the internal review had revealed not simply one physician's troubling judgment on a single evening, but a broader institutional failure to create an environment where staff like Denise Whitfield felt safe reporting concerns about a senior physician's conduct years earlier. Before the pattern extended to 11 separate patients, she testified that the board had already voted, independent of this hearing's outcome, to implement mandatory bias training across all clinical departments to establish an anonymous reporting mechanism specifically protected from retaliation concerns, and to conduct a full independent review of every case in which a patient's socioeconomic status appeared anywhere in documented clinical decision-making over the preceding 5 years, a review she stated would extend well beyond Dr. Castellan's own patient records. When it came time for my ruling, I addressed Dr. Castellan directly and told him that the evidence presented across this hearing, contemporaneous chart documentation from a physician who disagreed with him in real time, corroborating testimony from surgical staff, an independent clinical panel's determination that his conduct fell outside the standard of care, and a documented pattern extending across 11 patients over 4 years, left no meaningful ambiguity about what had occurred. I found that Dr. Castellan's decision on the evening in question, and the broader pattern the board's investigation had uncovered, constituted a serious departure from both the clinical standard of care and the basic ethical obligations every physician accepts upon receiving a license to practice medicine. I recommended, in the strongest terms available to this court in a civil licensing proceeding, that the State Medical Board pursue formal suspension proceedings against Dr. Castellan's license, a recommendation I want to note carries significant weight though the final determination rests with that separate body, and I ordered that Ridgemont Medical Center provide full and ongoing coverage for Harold Jennings's cardiac rehabilitation and any future treatment related to the diminished cardiac function his delayed care had produced, a cost the hospital's own board, through Eleanor Vance, had already voluntarily agreed to absorb in full prior to my formal order. I turned to Dr. Priya Nathan before the hearing concluded and told her directly that this court recognized fully what it had likely cost her, professionally and personally, to document her disagreement in real time against a surgeon with 22 years of seniority and a wing of the hospital bearing his name, and then to formally escalate that documented concern 6 weeks later once she learned of its consequences, a choice that a great many physicians earlier in their careers, understandably concerned about professional retaliation, do not make. And I told her that the entire institutional reckoning this hospital was now undertaking existed because one young doctor believed a patient's housing status should never determine the speed or quality of the care he received. Harold Jennings himself was present for the final day of this hearing, seated in the gallery in a wheelchair, his continued cardiac limitations now required for extended periods, and when given the opportunity to address the proceedings, he spoke briefly and without any apparent bitterness, stating simply that he had spent 3 years living unsheltered in this city being looked past by a great many people, but that the moment that had changed his life most permanently was not any of those years on the street. It was 20 minutes in an emergency room where a doctor with more power over his survival than almost anyone he had ever encountered looked at his address, or lack of one, and decided his heart was worth less urgency than someone else's, and he said that he did not know if he would ever fully recover the strength his heart had before that evening, but that he wanted the hospital, and any doctor watching this case, to understand that the 20 minutes it took to reach that decision felt, from where he was lying on that gurney, like the longest 20 minutes of his life. Roughly 5 months after this hearing concluded, the State Medical Board formally suspended Dr. Castellan's license pending a full review, and Ridgemont Medical Center announced, in a public statement Eleanor Vance personally delivered, the completion of its expanded 5-year review, which ultimately identified 16 additional cases across 3 other physicians warranting further investigation, a reckoning considerably larger than anyone anticipated when Dr. Nathan first filed a single complaint 6 weeks after a Friday evening shift. I think often about this case, more than most that have crossed this bench in recent years, because it illustrates something I have come to believe strongly over 4 decades of practice, that the most dangerous abuses of power are rarely the loud, obvious ones. They are the quiet clinical judgments made behind closed doors by people trusted precisely because their authority is rarely questioned, and that the entire structure protecting patients like Harold Jennings depends, in the end, on people like Dr. Priya Nathan and Denise Whitfield, junior staff members with considerably less institutional power than the physicians they were documenting concerns.